Electronic Health Records. This is Chapter 1, Lesson 1. The idea of computerized medical records has been around for over 30 years, but has only become a widely adopted practice over the past decade. Prior to the electronic health record, a patient's medical records consisted of handwritten notes, typed reports, and test results stored in a paper file system. Many medical facilities still use paper records in spite of the widespread transition. The push to transition to electronic health records came in response to studies and reports by the Institute of Medicine of the National Academies, that's the IOM, in the early 90s. Results of these studies asserted that the human and monetary costs of preventable medical records could be reduced through the adoption of the electronic health record. The IOM coined several the term electronic health records, but throughout the evolution of the EHR they have been called a lot of different names. Here are a few: computer-based patient records, electronic medical records, computerized medical records, longitudinal patient records, and electronic charts. The IOM reports also set forth 8 core functions of the electronic health record. Health information and data, that's a provision of health information and data to care providers on demand. Result management, management of computerized test results. Order management, management of orders related to patient care. Decision support for diagnosis, prescriptions, and prevention. Electronic communication and connectivity, provides connectivity between multiple care providers. Patient support for improved control of illness. Administrative processes and reporting, that's electronic scheduling systems that increase the efficiency of healthcare organizations and provide better, timelier service to patients. Reporting and population health, that's a statistical collection and reporting related to population health. Criteria for government incentive programs under the HITECH Act and strategies for developing a national healthcare infrastructure are built on these 8 core functions. Computer-Based Patient Records Institute, that's CPRI, also contributed to early thinking on EHRs and set forth 3 additional criteria. 1 is to capture of data at the point of care. 2 is integration of data from multiple sources. And 3 is provision of decision support. The introduction of HIPAA helped to broaden the scope of EHRs by defining how and in what way EHR information should be protected. Based on the principles set forth by the IOM, the CPRI, and HIPAA, the EHR can be defined as portions of a patient's medical records that are stored in a computer system, as well as the functional benefits derived from having an electronic health record. Social forces that drove the electronic health record adoption. Public safety remains the driving force in the adoption of electronic health records by healthcare facilities. The adoption is an effort to lessen the effects of a decentralized healthcare delivery system. Prevention of medical errors is another driving force. Increasing costs of health insurance also contribute to the push for EHR. Errors caused by ineligible orders, illegible orders, drug reactions, and duplicate testing drive up insurance costs. These costs can be greatly reduced through the proper use of the EHR. The government has taken additional strides to encourage the use of EHRs, offering incentives to doctors and hospitals that adopt electronic health systems. Changes in society have also made paper medical records outdated. Increased mobility of patients and patients seeing multiple healthcare providers are several. Technological changes such as the widespread use of the Internet has increased public interest in, acceptance of, and desire for the electronic health record. President Bill Clinton's administration issued an executive order instructing government agencies that conduct or oversee healthcare programs to implement proven strategies for reducing medical errors and creating a task force to find new strategies for reducing errors. Congress appropriated $50 million for the Agency for Healthcare Research and Quality, that's AHRQ, to support a variety of efforts and target at reducing medical errors. President George W. Bush established the Office of the National Coordinator for Health Information Technology, that's abbreviated ONC, under the U.S. Department of Health and Human Services. President Barack Obama identified the EHR as a priority for his administration and signed into law the Health Information Technology for Economic and Clinical Health Act, that's HITECH. This act promotes the widespread adoption of the EHR and authorized Medicare incentive payments to doctors and hospitals using a certified EHR. This will eventually level financial penalties for physicians and hospitals that do not. The HITECH Act is contained within the American Recovery and Reinvestment Act. The Office of National Coordinator for Health Information Technology, or the ONC, outlines 4 goals and 12 strategies for national adoption of health information technology that included Goal 1, to inform clinical practice. That is to incentivize EHR adoption, reduce risk of EHR investment for clinicians who purchase EHR to reduce risk, failure, and partial use of EHR. And strategy 3, to promote EHR diffusion in rural and underserved areas. Goal number 2 is to interconnect clinicians. Strategy 1, foster regional collaborations. Strategy 2, develop a national health information network. And strategy 3, coordinate federal health information systems. Goal 3, personalize care. Strategy 1, encourage use of PHR. Strategy 2, enhance informed customer choice to select clinicians and institutions based on what they value, including but not limited to the quality of care that providers deliver. And strategy 3, promote the use of telehealth systems. Goal 4 was to improve population health. Strategy 1 was to unify public health surveillance architectures. Strategy 2, streamline quality and health status monitoring. And strategy 3, accelerate research and dissemination of evidence. ONC updated the plan with the Federal Health IT Strategic Plan of 2008 through 2012. This plan has 2 goals with 4 objectives under each goal. They include goal number 1, patient-focused healthcare. The patient-focused healthcare includes 4 objectives, which are privacy and security, interoperability, adoption, and collaborative governance. Goal number 2, which is population health, includes 4 objectives, which are privacy and security, interoperability, adoption, and collaborative governance. The HITECH Act encourages the widespread adoption of the electronic health record by authorizing Medicare to make incentive payments to doctors and hospitals that use a certified EHR. Incentives intended to drive adoption of the EHR in order to reach the goal of every American having a secure electronic health record. Success requires three critical short-term prerequisites. Clinicians and hospitals must acquire and implement certified EHR in a way that fully integrates these tools into the care delivery process. Technical, legal, and financial supports are needed to enable information to flow securely to wherever it is needed to support healthcare and population health. A skilled workforce is needed that can facilitate the implementation and support of EHR, exchange of health information among healthcare providers and public health authorities, and the redesign of workflows within the healthcare setting. Providers that implement and have a meaningful use of a certified EHR prior to 2015 are eligible for incentives. After 2015, Medicare will begin to administer financial penalties for physicians and hospitals that do not use the EHR. HITECH Act required the ONC, in consultation with other appropriate federal agencies, to update the 2008-2012 strategic plan. The update must include specific objectives, milestones, and metrics with respect to the following. 1. The electronic exchange and use of health information and the enterprise integration of such information. 2. The use of an EHR for each person in the United States by 2014. Number 3. The incorporation of privacy and security protections for electronic change of an individual's identifiable health information. Number 4. Establishing security methods to ensure appropriate authorization and electronic authentication of health information and specifying technologies or methodologies for rendering health information unusable, unreadable, or indecipherable. 5. Specifying a framework for coordination and flow of recommendations and policies under this subtitle among the Security, the National Coordinator, and the HIT Policy Committee, the HIT Standards Committee, and other health information exchanges and other relevant entities. Number 6, methods to foster the public understanding of health information technology. And 7, strategies to enhance the use of health information technology in improving the use of healthcare, reducing medical errors, reducing health disparities, improving public health, increasing prevention and coordination with community resources, and improving the continuity of care among healthcare settings. And number 8, specific plans for ensuring that populations with unique needs, such as children, are appropriately addressed in the technology design, as appropriate, which may include technology that automates enrollment and retention for eligible individuals. The HITECH Act specifies the following 3 components of meaningful use. Component number 1 is the use of a certified EHR in a meaningful manner. Number 2, use of the certified EHR technology for electronic exchange of health information to improve quality of health care. And number 3, use of certified EHR technology to submit clinical quality measures, that's CQM, and other such measures selected by the Secretary of Health and Human Services. CMS officially published the Electronic Health Record Incentive Program Final Rule on July 28th of 2010. It defines the criteria for determining meaningful use. It implements incentive payments over 3 stages. Eligible professionals must meet 20 out of 25 meaningful use objectives to receive payment. 15 objectives are core objectives that must be met. The other 5 may be chosen from a list, and that list happens to be on page 11 and 12 in your textbook. Eligible hospitals must meet 14 core objectives and select 5 others from a list of 24 to receive payment. You can see page 12 of your textbook. Under the CMS EHR incentive programs, eligible healthcare providers must adopt a meaningful use as certified EHR that has been certified by an ONC authorized testing and certification body. That's ONC ATCB. ONC certification criteria represent the minimum capabilities an EHR needs to include and have properly implemented in order to achieve certification. Before the HITECH Act, the Certification Commission for Health Information Technology, that's CCHIT, was created to reduce the risk of providers who adopted an EHR. CCHIT is an ONC ATCB. Aren't these acronyms wonderful? CMS has specified a number of clinical quality measures for meaningful use. EPs must report on 3 required core or alternate core CQM and 3 additional CQMs selected from a list of 38. Hospitals must report on 15 CQM. ONC certification requires an EHR designed for an inpatient setting to be tested and certified according to all of the clinical quality measures specified by CMS. That is the end of lesson number 1, and we will get you on to lesson number 2 shortly.